Hello, I'm Keith Blankenship, a Vice President with Lumeris, and I'm also on the faculty of the Accountable Delivery System Institute. And today I'm going to be talking about information technology for clinical integration and how that can lead to accountable care. If you look at today's current healthcare system, what you see is a number of systems in the field. These could be ambulatory EMRs for the physicians, acute EMRs for hospitals, payer systems with the insurance companies, pharmacy systems, lab systems, a number of systems. All of these systems do their jobs quite well, but none of them talk to each other. And usually what you end up having is the patient acting as the system integrator, the one who shares information from the ambulatory EMR to the acute EMR, or from the payer to the ambulatory physician. We've all heard stories about seniors who go to the emergency room with all their prescriptions in a Ziploc bag just so the doctor can know what medications they are taking. Obviously, this is not the way we want healthcare to be. So how did we get here? If you look at it, the first attempts at automation is what we call level 1, which was really taking paper records and putting them into computer systems. And this is what most ambulatory and acute EMRs are based on. Again, they do the specific job of automating the paper quite well, but they've created islands of automation that don't talk. What this has led to is some pretty complex workflows. Here's the workflow of a hospital that we worked with, which shows the movement of a patient from a PCP office into the hospital setting and then to a cardiologist after release. The PCP is on one EMR, the hospital is on a second EMR, while the cardiologist is using a third EMR. All the white boxes you see on the screen represent manual steps that have to be performed because those systems do not talk to each other. Again, this is not how we want healthcare to be. This is overly complex and overly costly and puts a huge burden on the patient. So the second attempt at automation was really connecting these islands through what we call unintelligent pipes, where the ambulatory EMR could pass discrete information to the acute EMR when appropriate, or the acute EMR could pass information to a payer system. Again, these were discrete pieces of information, usually episodic in nature, and kind of when forced that way. Health information exchanges, or HIEs, were the attempt at this. And again, it has not worked. Why hasn't it worked, or what's been the problem with it? Well, here's an example of a hospital system that we've worked with. It has 15 hospitals and over 25,000 employees. It has owned physicians and specialists in the community. It even has its own HMO health plan for its employees. It's integrated a single EMR across both the acute and the ambulatory settings, that being Epic. They have thousands of employees, or IT employees, working on this very problem with a dedicated data integration team. But they are still struggling with data integration, even though this looks like the perfect model to achieve clinical integration. And one of the reasons for that is the attempt in level 2 really was around point-to-point integration. So you would start with an acute EMR and hook it directly to an ambulatory EMR. And then when another ambulatory EMR came along, you would hook directly to it, and the third. Then you would hook to lab systems and pharmacy systems, and you ended up with a number of point-to-point connections that became very complex and very difficult to maintain. So what we believe clinical integration should look like is what we call level 3, which is where the platform or the system is integrated, it's aligned, and all the parties involved in healthcare are informed. So what you end up with then is the right people getting the right treatment in the right setting. So you really have the patient at the center of the system again, but the patient is no longer the integrator of the data, but is truly the receiver of the care and the receiver of the improved efficiencies that are brought about by this level 3. And so then you end up with all parties involved having clear accountability for both the clinical outcomes but also the financial outcomes. Well, that sounds like a worthy goal, but how do you really get there? This is a somewhat humorous plan for how to move from having data such as claims and prescriptions to EMRs, and how to get to clinical integration and accountability. But as you can see here, step 2 is a little fuzzy. Probably needs a little bit more work than expecting a miracle to occur. So how do you truly achieve that? We believe that there are 5 building blocks required for clinical integration. It starts at the very lowest level with your infrastructure, works through integration, data aggregation, performance analytics, and then finally the communication. When you look at infrastructure, it's key because it is really what supports the entire technical architecture. It's the hardware, the servers, all those things that are needed to run the computer programs that are required for clinical integration. But there are a lot of challenges around it, including the high level of system availability now required, because clinical integration really requires 24/7 support and availability. You're also connecting multiple sites. You've now moved outside the 4 walls of the hospital or the payer, and are touching physicians' offices in the community, mobile devices, just ubiquitous communication across the entire network. You also have security concerns. You're now working with a lot of personal health information. You must make sure HIPAA and other rules are followed and that data is secure. And then finally, in order to do all this, you have a high cost, both in the capital equipment required, but also in the humans that have to support that equipment. The next layer is integration, and this is how the data is passed. This is how the ambulatory EMR is hooked to the acute EMR, or how data is moved from the lab into the hospital. But again, there's numerous challenges around this one, including how do you connect those multiple sites? How do you get connectivity into that doctor's office? How do you make that last mile leap? Then there's also varying interface standards. There's been a lot of attempts in the past years to come up with standards of how these systems will talk. But even when a standard is used, there's still interpretation. There's still misunderstandings about what one field may mean. So standards have helped, but they have not solved the problem. And as I mentioned earlier, it's really the access to those non-owned systems. So how does a hospital or a payer get access to the ambulatory EMR in the physician's office? How do they work together? The third layer is data aggregation. So you have all this data that's flowing through the system because of your infrastructure and your integration, but now what do you do with the data? How do you convert that data into a usable model that can help you solve problems, can really truly move you toward accountable care? And the challenges with data aggregation is, first off, acquiring the data, which integration helps with, but then moving it into a meaningful data model and meaningful views that can truly allow you to say, tell me everything you know about patient A, and show that to me in a way that's meaningful. And it also works with, how do you know patient A coming from the ambulatory EMR is the same as patient A coming from the acute EMR? So those are all challenges within the data aggregation. How do you pull that data together? Also, on a very practical and physical level, you're having to store a lot of data. How do you store that? How are you able to have the hardware to store that? How are you able to store it in a way that it's still accessible in a timely fashion? The next layer is the performance analytics. This is really then taking that data and coming up with actionable intelligence on that data. What do you want to tell the physician? What do you want to tell the payer? What do you want to tell the medical director about that data, and in particular that patient? Some of the challenges you have around that, first off, is what we call the signal-to-noise ratio. We have found that usually you can come up with too many actions for a particular patient. And you don't want to tell a physician all of these when they're sitting with that patient. You want to identify the key ones. What are the key pieces of information that physician needs to know when they're sitting across the exam room from that patient? Also, then again, communicating to the right user at the right time. So some information needs to be delivered to the physician when they're with the patient, but other information is for other settings. And how do you deliver that? How do you determine how that should be communicating? Also, you want to have that information enabled directly into the workflow. If the user of the system has to leave their current setting and move to another system, log in with a separate username and password, navigate through a number of screens, that just doesn't work. That information needs to be available at the right time, at the right place, when it's needed. We also think it's important to track the results as well. As recommendations are provided to a physician, it's important first to get the physician's feedback. Does the physician agree? Is there a reason he doesn't agree? And to use that to build up a record both of the efficacy of those recommendations as well as the particular patient. Then you also want to follow that patient down line and see how that health improves because of that recommendation, and then adjust recommendations in the future. And then finally, the last layer is the communication, and that's getting the information out to the right place at the right time. Again, this is inserting the analytics into the existing workflows. Challenges you have here are there's multiple systems. There's even multiple variations of systems out there. So while 3 doctors may be using the same EMR, they may be on different versions. It may be configured differently. And so then you're also dealing with different security models. How do you know who the user is? How do you achieve things such as single sign-on, or again, inserting the data into the system? And of course, here you also have usability considerations. So all of these are extremely important and must be addressed in order to truly achieve clinical integration. But what does it look like when it works? What you end up having is really at the core your clinical data with your performance analytics around it, but it allows you to look at that data on really 2 different planes. One is a population plane, where the information is worked at varying layers, where you're able to start at a population and work through a product and then maybe work into the disease states such as your diabetics, and then ultimately work down to a patient. And this is truly population management, but with that same data, you're able to do patient-specific views of that as well across the continuum of care, so that the PCP and the specialist and the acute settings and the ancillary providers, everyone is looking at the same data and has that complete picture of the patient. You're all working from that same picture. And this is now possible because of the connectivity we have with wireless devices and with the internet, so that you can truly see this information exactly when you need to see it. So I hope today I've shared a little bit about the challenges around clinical integration and the parts that need to be built up in order to truly achieve accountable care. Thank you for your time.